We are so excited to be able to do this joint webinar. And if you would be able to go ahead and share your region and your name in the chat, so we can see who all is here as we're starting to pull up our PowerPoint. All right. We are so grateful to be able to do this as a joint effort between PediECMO, EuroELSO, and ESPNIC. If you are interested in learning about any of these organizations, the QR codes below will take you directly to those websites. If you are a part of one and not part of another, and you're interested in being on the email list for any of them, just go to those websites and it'll show you how to get involved. I really appreciate all of our panelists here today. Again, if you are just logging on and just jumping on, if you would please put your name and sort of your region or your organization in the chat so we can keep track of who all joined and from where across the world people have joined. So PediECMO has been doing webinars quarterly for the last couple of years, and we have all of our webinars on our YouTube channel. If you are interested in seeing past ones or seeing this one once we get it uploaded to the channel, or passing it along to somebody who wasn't able to join, this is the QR code to go to the YouTube channel. You can also just search you can also just search the PediECMO YouTube in any of your search engines. And then we are also able to offer continuing medical education through AMA PRA Category 1 credits for this session. So if you're interested in doing this, the way to do that is on the left side of the screen. You just text that code. We'll also put this code up at the end of the session as well too. So just give people a second to look at that code and document it. All right, I'd like to introduce and thank all of our panelists for joining us today. I am actually going to have you guys introduce yourself and tell us a little bit about yourself and where you're from. And so Dr. Di Nardo, we'll start with you.
My name is Matteo Di Nardo. I am a pediatric intensivist working in Bambino Gesù, the pediatric intensive care unit in Rome, Italy.
Great. Dr. Potera.
Hi, I'm Renee Potera. I'm a pediatric intensivist at Phoenix Children's Hospital in Phoenix, Arizona, and serve as the Associate Medical Director for ECMO.
Dr. Reschke.
Hi, everyone. I'm Agnes Reschke. I'm a pediatric intensivist as well as a pediatric oncologist currently practicing at Cincinnati Children's.
Great. Dr. Wösten-van Asperen.
Hi, I'm Roelie Wösten-van Asperen. I'm a pediatric intensivist in Utrecht in the Netherlands. And I'm currently the chair of the Onco-Critical Care section of ESPNIC.
And then Dr. Zinter.
Hi, everyone. Matt Zinter, University of California, San Francisco, Pediatric ICU.
Great. Well, thank you guys so much for joining us today. And Dr. Aparna Hoskodi is actually going to be helping me moderate, and she will be manning our chat. So if those participants or people that are watching have questions, please throw them in the chat, and so that we can keep track of that as we go on. And we'll try to have some natural breaks in the conversation to address those questions. So we actually are going to start with a clinical case. So we have a 9-year-old boy with a history of high-risk AML who presents to the pediatric intensive care unit with progressive respiratory failure. He has a history that includes a diagnosis about a year ago of his AML, followed by induction and then consolidation chemotherapy. He achieved remission, but was found to have some measurable residual disease. And so given his high-risk cytogenetics, he underwent a matched unrelated donor hematopoietic stem cell transplant about 3 months ago. His post-transplant course has been complicated by a grade 2 acute graft versus host disease of the skin, which has been treated with systemic steroids and tacrolimus. He has remained on immunosuppression therapy and antimicrobial prophylaxis since that time. And about 1 week prior to hospital admission, he developed some low-grade fevers and a non-productive cough. A respiratory viral panel was negative at that time, and he was managed supportively. And then his symptoms worsened and imaging revealed the development of a pneumonia. So he was admitted to the hospital due to treatment for his pneumonia and for an oxygen requirement. He received supportive therapy, and then about 3 days after his admission, he started to have worsening respiratory failure and an increased oxygen need. And so he was transferred to the pediatric intensive care unit and ultimately escalated to invasive mechanical ventilation. He just was placed on lung protective ventilation and antimicrobial and antifungal coverage and conservative management, but despite conservative fluid management, but despite all of this, he continued to have some escalating oxygen requirements. And so, which mean sort of just to give you guys some numbers, his PF ratio is 77 and his oxygenation index is 26. And so the team started to have some discussions around ECMO candidacy, in particular VV ECMO candidacy. So stem cell transplants and patients and ECMO candidacy has been a little bit controversial over the years. And Dr. Di Nardo, in the past, you have actually published an ELSO registry data study regarding the outcomes of these patients. Can you give us some historical context on what clinicians have typically encountered in regard to challenges when working with this patient population on ECMO?
Yes, sure. As you can see, the paper that you cited was dated 2014, and there was a paper dedicated to the examination of the ELSO registry for this population that was very niche at that time, because the number of patients that was collected was very small. This paper substantially, with all the limits of the ELSO registry, said one important thing, that at that time, in the court evaluated the survival to hospital discharge was very low, 10%. So this was the beginning of an increase of curiosity from researchers, intensivists, hematologists, trying to check if in the following years things have improved. And I was really surprised to see how in the last 15 years, for many reasons, the survival of this patient receiving ECMO with hematopoietic cell transplantation has slightly increased. There were other papers after this, a small collection with a different survival rate, 25, 30, someone also 50%, which were quite encouraging. Yes, all of these. In particular, the one that you showed, the first one of Taylor Olson, according to me, is one of the most significant one because it collapsed all these patients, including also the one that we studied in our cohort in 2014, and they found complexively a better survival, around 19%. But the author were so clever to put the lens on the last decade, and they saw that in the last decade, the survival increased significantly, reaching 26% almost, which is a nice survival for this kind of patient that, according to me, are the most complex one, where the immunocompromised state is the most severe because the cells providing the immune system are lacking in this period. And this paper encouraged the scientific community to go on and to provide, I would say, statement or recommendation to support candidacy at bedside, to choose among the worst the best candidate, and so on.
Yeah, so yes, in recent years, we've had some studies that have shown increasing survival, which is great. And Dr. Potera and you, Dr. Di Nardo, were also involved in a survey study about evaluating ECMO candidacy in children with stem cell transplants and CAR T therapy. Can you tell us a little bit about your findings in that survey? And Dr. Potera, I'll start with you. What did that sort of survey tell us about the opinions and practice patterns of clinicians and how they've changed in regards to this patient population?
Yeah, so as Dr. Di Nardo was just saying, we've noticed an improvement in these patients' outcomes over time. And so we were interested in finding out if, that has changed the opinions of pediatric critical care physicians and oncology physicians over time. There's been a lot of advances both in critical care management and in oncology management of these patients. And so we found that almost everyone, so 99.5% of the people surveyed said that patients with stem cell transplants were ECMO candidates, but should be each considered individually, given that they each have their own, risks and their disease processes are different. The one interesting thing was, and it wouldn't be surprising to any of the critical care doctors on here, but the critical care physicians listed more contraindications than the oncology physicians. Specifically, they were more worried about patients who had multi-organ failure rather than single organ system disease. Patients who had active pulmonary hemorrhage were considered to still be high risk. And then when we went into the CAR T cells, which are obviously were newer technology, 63% of the respondents felt that they should be thought of differently than other stem cell transplant patients, and that if they were on their second CAR T treatment, then we should maybe think about not offering those patients ECMO. Interested in what Dr. Di Nardo has to say about those topics as well.
Dr. Di Nardo, any additional thoughts?
Well, no more than this. The most striking things, as Renee was saying, was related to the CAR T therapy that were quite new at the time and were recognized a little bit different in terms of candidacy compared to the hematopoietic stem cell transplant patient. It seems that the scientific community is more keen to support this patient, maybe due to the fact that there is a lot of innovation and innovative therapies in those patients. So this could probably foster or encourage the people to do something more compared to what was done in the past. Many of these patients, as you can imagine, arrives to the transplantation or after the CAR T therapy are with more organ failures compared with the one just receiving stem cell transplantation. Despite this, the community was more keen to go on and support.
Great. So Dr. Reschke, Dr. Zinter, and Dr. Potera, you were all involved in this retrospective multi-center study of oncologic and stem cell transplant patients on ECMO. It was done throughout 16 different PICUs. And so what insights did this study give us about the outcomes for patients with an oncologic diagnosis alone versus those with stem cell transplant after an oncologic diagnosis or stem cell transplant after a non-oncologic diagnosis? Dr. Reschke, I'll start with you.
Yeah, so Renee was the senior author on this study, and it was actually a really incredible study in terms of the granularity of data that we collected. And so we were able to get a lot more information in terms of what made a good candidate versus a bad candidate. And so the paper that you're alluding to is the main paper that looked at survival to ECMO decannulation as well as survival to hospital discharge. And for oncologic patients, the survival to ECMO decannulation was about 52% versus 64% for BMT patients, which was a little bit surprising. And then hospital discharge was 37% overall, with 36% survival to discharge for oncology patients. And 42% survival to hospital discharge for BMT patients. And then we currently have sub-analyses that are in the works. One is a bone marrow transplant sub-analysis paper, and another is an oncologic sub-analysis paper that are one submitted for review, the others still in the process of manuscript, of preparing the manuscript, but specifically looking at the BMT sub-analysis. About 3/4 of those patients had a malignant indication. And they specifically looked at the co-infection rates and things like that, and whether there is any impact on survival. And what they found in that sub-analysis, or what we found in that sub-analysis paper, was that there wasn't necessarily a difference, and that having an active infection didn't increase your chance of successfully decannulating versus not. And the most common complication was bleeding. And then in the ONC sub-analysis paper, that looked at 124 patients. And we specifically tried to see if there's oncologic factors that portended a good prognosis versus a bad prognosis. And so first we kind of subdivided it, looking at hematologic malignancy versus solid tumors. And the survival to ECMO decannulation was about the same, at about 50 to 55%. What was interesting, though, was that the survival to hospital discharge really varied between solid tumor and hematologic malignancies, with a survival of 36% for leukemia patients, or for hematologic malignancies, and 26% for solid tumor malignancies. So that's kind of where that breakdown came apart. And then what we found that was probably the most notable was that patients who were not in remission had much worse survival than everyone else, with a survival to hospital discharge of 27%. But obviously Renee was the senior author, and so I'll hand it over to her.
I think, one of the things that we found, and again, we probably had the largest patient population, but still a small number of patients on retrospective study. But we did find that patients who received a stem cell transplant for non-oncologic diagnosis, so those with, other indications, actually had the highest hospital survival to hospital discharge. So their survival to hospital discharge was 56%, compared to the 37% that we had for oncology patients, and 42% for those who received stem cell transplant for an oncologic disease. So, and that, I think, goes along with some other publications that have seen similar things, that if you get a stem cell transplant for a non-oncologic diagnosis, then your outcomes at ECMO are a little bit better.
Yeah, definitely some interesting findings. There have been two papers that have been published. Dr. Di Nardo, you were the lead author on one, and Dr. Zinter, you were the lead author on another, really just providing guidance on ECMO candidacy in this patient population. And many of you were also sort of on these papers in addition. And so what are the most important factors that need to be considered when evaluating ECMO candidacy in this patient population? Dr. Zinter, I'll start with you.
Thanks. Yeah, it's a good question. I think I will say both of these papers were really challenging to write, as I think you can all imagine. And for the one published in Peds Crit Care Med, we were very deliberate about not being too prescriptive. We started really wanting to provide more concrete guidelines, and we just could not agree on everything, as you all can imagine. And so we ended up being a little broader. But some of the themes were how reversible is the underlying either disease or process. So, like, for example, the vignette that's being proposed with a high-risk AML patient who's about 3 months out from stem cell, we would absolutely want to hear from the transplanters about, whether they think this patient is high likelihood to relapse, if they've done disease surveillance post-transplant, those sorts of things. I think the other things to consider, of course, for all ECMO candidates, but certainly for this population, is bleeding and clotting complications. So, for example, does the patient have uncontrolled alveolar hemorrhage? How are they able to maintain or not maintain their counts? Do they have clotting everywhere? Do they have systemic issues like transplant microangiopathy that might predispose to circuit complications? And then there were some sort of broader themes as well related to the graft function. So, is the patient engrafted? What sort of immune reconstitution do they have or not have? And how much immunosuppression are we using here to control or graft versus host disease? Those would be just some of the big picture themes we were discussing here.
So things that would make this patient, our patient that we've talked about, a little bit more high risk would be the sort of the high risk cytogenetics, and if he was having any complications outside of maybe the graft versus host disease, and how well those complications were being managed. Is that correct?
Yeah, and of course, there's so much detail about these patients, but those general themes I think are relevant. And even how much preceding chemotherapy the patient has had and what their organ function was going into stem cell transplant. Some patients with really high risk disease go through years and years of cycles of chemo, and others are ushered to transplant very quickly. And so, there's a lot of nuance there about how much organ dysfunction they have accumulated going into the transplant that could sort of explain why they're as sick as they are now.
Yeah. So it really sounds like we would need to rely on our oncology colleagues to kind of help guide some of that decision-making process. I'm curious, are there any specific pathogens that if this child was infected with that would make ECMO use more controversial? Dr. Wösten-van Asperen, if you'll answer that one for me.
Yeah, I think, well, we don't have granular data on, well, perhaps they are coming from the US group on pathogens. I think everyone will agree that a fungal infection has a poorer prognosis than a bacterial infection. Viral infections depends on what is possible on active therapy. And I think for this patient putting on ECMO, I want to know the prognosis or the reversibility of the acute critical illness, why this patient is on our ICU, what's the degree of organ failure, and what's the reversibility or the chances of recovery of these when there is multi-organ failure. I think that's also a factor which need to be taken into account before putting a patient on ECMO.
What would you say would be something that would be like a favorable feature that would make you more willing to put a patient on ECMO versus not?
I think if there is a response on antimicrobial antimicrobial therapy or antifungal treatment, if you see a response, you just need to bridge time to recovery, and then ECMO might be useful. But if there is a persistent sign of active fungal infection, no control of the inflammatory condition of this patient, despite a lot of antibiotics, antifungal treatment, then there will be a discussion whether or not this is a favorable candidate for ECMO. So I think timing, how long is the patient on mechanical ventilation? We still don't know the most optimal timing for considering ECMO. That's our things. Well, we will be discussing it probably at the end, what the knowledge gaps still are, but there are a huge amount of knowledge gaps because we are all relying on retrospective data in a highly selected population because we are considering patients on ECMO without a comparison with patients who were not on ECMO and perhaps with severe lung disease. So there, we still need more research.
Yes, definitely.
Yeah.
Just to the whole group, I guess one of the questions would be, do you feel like there are any absolute contraindications to ECMO in this population? You know, it used to be that stem cell transplant people, some centers considered that a contraindication, and now I think a lot of people have gone away from that. But do you feel like there are any contraindications in your mind that you could say were hard and fast? Dr. Di Nardo, I'll start with you.
Well, personally, the pre-engraftment period for me is the most difficult to manage. In particular, if there are viral infection, fungal infection. It's also tricky for bacterial infection, but at least we have the possibility to target therapy. For the other two, viral and fungal, we need a substantial immunoreconstitution that is not frequent over there. Another contraindication for me is a poor graft function, I would say, not only related to the platelet, but let's say let me pass the word, a weak in immunoreconstitution. Poor graft function can be defined much more better than what I said. But in those cases, when there is a trilinear form of loss of immunity, so no cells that can be due to pharmacological treatment, but this trilinear poor graft function is due just to a graft that has not achieved its best. I think that it's another important contraindication.
Dr. Reschke, I would love to hear your thoughts on this question.
Yeah, there's a couple big ones in my mind. One is bleeding with refractory thrombocytopenia, which we obviously encounter a lot, especially in like the early stages of engraftment or pre-engraftment. Another is the reversibility of the underlying etiology. I think at least at our institution, that's a big one, and so that'll be an interesting point of discussion for this case. And then the duration of mechanical ventilation. And so institutionally, we look at mechanical ventilation for more than 1 week as a contraindication to VV ECMO and more than 2 weeks as a contraindication to VA ECMO. And then lastly, I would say organ reserve. So if they have like concomitant liver failure, then to me, that would also be a contraindication.
Interesting. One of the questions that we had that had been brought up by our PediECMO group was that at this person's institution that they would not offer VA ECMO to some of their stem cell transplant patients just in general. And I'm curious to know y'all's thoughts and why the week versus 2 weeks as the sort of cutoff with VV and VA. Dr. Reschke, I'll start with that.
Yeah, so I'm obviously very biased, but I believe that every BMT patient should at least be evaluated for candidacy with some of those, strict contraindications and then some relative contraindications in place. And then for us, For VV ECMO, if you have, what we found, at least institutionally, is if you've been intubated for more than 1 week, especially at that point, you often are requiring really high ventilator settings. And so it's unlikely or less likely that you'll be able to recover your pulmonary function at that point in the context of a BMT. As opposed to for VA ECMO, when you're going on for, mixed reasons, then the degree of, lung dysfunction is less of an active issue.
How about others on the panel at your institutions? Is there a similar decision-making process? Would you offer VA if say this child was also in shock and needed VA ECMO? Dr. Potera, how about it in Arizona?
We do and would offer VA ECMO for these patients. In the HOPE study, for example, like our highest survival was children who went on for respiratory failure, but there was actually no difference between VA or VV ECMO for as far as survival. While we take into account the amount of time they're on the ventilator, like we don't treat that as absolute contraindications. We take it into account with everything else that's going on with the patient. So, if they have multi-organ failure and have been on the ventilator for a week, that's a little different than if they just have lung disease and have been on the ventilator for a week. So, as suggested by all the consensus statements, it's more of a multidisciplinary discussion. The only things that we in our institution consider as absolute contraindications is that we don't do ECPR for bone marrow for stem cell transplant recipients based on data from several papers showing that their outcome is pretty poor with ECPR. And then if their survival is less than 30%, is another thing that we consider a contraindication. Other than that, we don't have a lot of absolute contraindications at our institution.
Okay. I am curious about your experience, Dr. Wösten-van Asperen, in terms of if you would offer VA if this child was in shock as opposed to just respiratory failure.
Well, we are not an ECMO center, so if we offer patients ECMO, we transfer these patients to another hospital half an hour away from Utrecht. So we don't have strict cutoffs. It's a multidisciplinary discussion with the ECMO team of Rotterdam and our ICU team together with the oncologist. And it's different from patients to patients. So we are not have strict cutoffs more than a week mechanical ventilation, then no VV ECMO. It really depends on per patient. So, and if the circulatory condition is good enough to have VA ECMO, well, we offer them for VA ECMO, but not under strict conditions like the Hospital of Agnes.
Well, it sounds like there's a wide variety of practice across institutions, which is not surprising. It does sound like we might have a question in the chat. I think.
Yeah. I can see a question here from Joanne Starr. What is your approach to supporting these children who have got resistant organisms? And do you have a different approach? Who would like to take this question? Matteo first.
Well, in general, when we have a multi-resistant pathogen, we are very reluctant to go on ECMO if we know this in advance. Often it happens that we are already on ECMO and we need to do as much as possible of what we can. So before ECMO, I would consider the extreme pathogen resistance as a contraindication.
That's a good point. And Renee, in your HOPE study, did you have a proportion of children with like multi-resistant organisms?
So we didn't have that data as far as if they were resistant or not. I wish we did. And I know that in the sub-analyses, they're working more on trying to determine those types of things. But yeah, we don't have that data.
Anyone else from the panel? Roelie?
I think if I can just add in, I mean, I
Matt?
think
Yeah,
there's a
please.
distinction between an organism's resistance and its virulence. And so oftentimes the most resistant organisms are also highly virulent, like Klebsiella and other gram negatives. But if the problem is that the patient was on the wrong upfront therapy because they were started on empiric cefepime and it turns out that they need a different treatment course, that's very different, right? Because now you're switching to the proper therapy, which was unanticipated in the beginning. That's different than a patient is failing medical therapy because of a resistant profile. So, we would all be very concerned, but I would want to hear the nuance from the infectious disease treatment about what the treatment options are or aren't in light of the most recently available therapeutics.
Thank you, Matt. Roelie, a final comment on this?
Yeah, I think it all has to do with if you can bridge towards recovery. So the reversibility of the clinical condition. So if there is you started with the wrong therapy, but after you got your cultures, and you have treatment for this patient, that's a whole different story than a resistant organism failing therapy. The prognosis of the last patient will be different from the first one. So it all depends on what are your possibilities for treating these patients while on ECMO and the chance of recovery.
Great. Alrighty. So moving forward with our clinical case. So the patient was deemed to be an ECMO candidate, but the team actually determines they would like to optimize and escalate his respiratory support prior to cannulation. So his ventilator settings are escalated to a pressure control ventilation with a peak inspiratory pressure of 36 and a PEEP of 14 and a rate of 24 and an FiO2 around 50%. And this holds him steady on his oxygen saturations around 88 to 92% for about the next 12 or so hours. And then he starts to have a drop in his oxygen saturations and he ends up being escalated to the oscillator. And his settings on the oscillator are now a mean airway pressure of 28, a Hertz of 7, and a delta P of 55 and up to 65% on his vent. His gas on these settings is 722 pH, PaCO2 of 60, PaO2 of 52, and this makes his OI 35. He's also now hypotensive and requiring some vasoactive medicines to keep his blood pressure where you want it to be. He's also not peeing as well now. So now the team would like to proceed with ECMO cannulation. And so I think the big question was the decision to hold off on ECMO cannulation until a worsening respiratory status or higher vent setting requirement the correct way to manage this patient, or should there be an earlier initiation considered? And I think somebody alluded to this a little while ago, but Dr. Reschke, I'll start with you.
Yeah, if you don't mind, I just want to take one step back just in terms of the ECMO candidacy discussion, just to put my oncology hat on. So one thing that we've kind of alluded to but hadn't explicitly called out was, and Dr. Zinter had specifically talked about what the patient's prognosis is. And so typically at an institution, you'll ask your oncologist or your transplanter, is this patient curable? And what we've kind of found is that using that vague question, us oncologists tend to be optimists. And so we'll say, oh yes, every patient, regardless of everything, is always going to be an ECMO candidate. And so it's important to really specify what you're asking. And so Renee had also kind of alluded to this, but the 30% survival at 1 year is kind of mark that we use at our institution. And so the question that I would also ask the oncologist in this case is, does this patient have a 1-year survival of at least 30%? Just explicitly, use that terminology. And in this particular case, for a patient with AML that had MRD positivity, high-risk cytogenetics, is now about 3 months post-transplant. We don't know his disease status, but assuming he's in remission, I would give this patient about a 50% survival overall. And so I would say that using those metrics, this patient would be an ECMO candidate just from that standpoint.
Yeah, that's great, like objective way to think about that.
And then to answer your specific question, I'm a big believer in cannulating these patients early. Again, institutionally, we use an OI greater than 25 for 12 hours as kind of our threshold, since we found that cannulating early is important for survival. And so I personally would have cannulated this patient earlier, but obviously hindsight's always 20/20.
How about other members of the panel, Dr. Di Nardo?
Well, we are not so early cannulators, I would say. We like to do everything is possible cautiously in terms of mechanical ventilation setting, so including all from nitric oxide, setting of PIP properly according to lung mechanics, in case of also prone positioning, not taking too much time among all this maneuver. Then if all of these fails, we go directly on ECMO.
Dr. Zinter, how about you guys? Would you guys have cannulated this child earlier? Do you think they should have been cannulated earlier, or is there any data to tell us what we should use in terms of markers like oxygenation index, lactic ventilator pressures that are different than our other ARDS, pediatric ARDS population?
Yeah, it's a great question. In my gut, I want to cannulate patients earlier so that we can give them the benefit of lung rest and we can start doing other things we need to do, like more diagnostics, bronchoscopy, whatever. But I think the truth is we don't actually know truly that is the right way to manage these patients. And I think for me, the number one consideration about timing of ECMO is once you've agreed that a patient is a candidate is really about when you can do it safely. And so if that means waiting to get the proper people, if that means truly obtaining really good informed consent about the pros and cons and risks and benefits, then I think sometimes it is worth waiting a little bit longer. But I mean, I think we'd all generally agree that you don't want to wait really, really long time. But the fine line, I don't think we know exactly when the right time is.
Okay. Dr. Wösten-van Asperen, you sort of alluded to this in the answer to one of your questions before, the same sort of thing. We're not entirely sure when the best time to cannulate is. And any other thoughts?
No, I think that is one of the questions we need to answer in the future. I fully agree with Matt. We don't know the thresholds for OIs. We don't know the most optimal timing. There was a recent study of the adult ICU group from Elia Zoulet, the 9i investigators. They conducted a prospective study. It was published in Intensive Care Medicine in October, I think, last year, where they compared, they followed the trajectories of patients on mechanical ventilation, and then to their surprise, they found the patients with severe oxygenation problems, that there was no difference on when they accounted for age and oxygenation severity. There was no difference in 90-day mortality between the group who was on conventional mechanical ventilation and the group who proceeded to ECMO. So I think it's still institutional. You have institutional protocols, but to be honest, we don't have the data to set thresholds. And well, in adults, the mortality even on invasive mechanical ventilations are much higher than in children. They are with severe ARDS 80%. So there is an 80% mortality on a conventional mechanical ventilation, and also 80% when patients were with the same OIs on ECMO. But while we still don't have the data, I think it's a great opportunity to start such a prospective study to get the data, because we now all making our protocols based on retrospective data, but these are the selected patients who were considered to be a candidate for ECMO. If we copy the Jelena study, I think then we will have more granular data to talk about timing of ECMO, thresholds of oxygenation in the indexes, role of a multi-organ failure, yes or no, to determine who is may have benefits of ECMO and who are really not a good candidate.
Yes, it sounds like we definitely have a lot of things to study in the future. I believe we've got some questions in the chat.
Yeah, thank you. Some nice questions coming up. So thank you to everyone who are posting questions here. One question Paige has put in here, which is one thing our institution has struggled up with is coming up with guidelines around ECMO candidacy and the degree of multi-organ dysfunction beyond pulmonary and cardiac failure, such as renal and liver dysfunction, and whether it is acute versus chronic. Do you have individual organ failure stroke dysfunction scores like KDIGO that you may use as cutoffs? And does it change your strategy if the dysfunction is acute versus chronic? Matteo?
No, we don't. In general, we are more worried when the liver function is failing, so the acute liver dysfunction. When it's chronic, it means that there is at least some protein production, the coagulation is stable, so we are more prone to do it. One of the things we are more reluctant instead when there are comorbidities like sinusoid obstruction syndrome, where we are not able to quantify properly how the liver is going on. And when we are also aware that the treatment of this disease requires some drugs that can increase the risk of bleeding. So in this case, we don't say it's a contraindication, but we are more worried to go on. Also because we don't have data in support of this.
Thank you, Matteo. Anyone else wants to add to this? Matt, Roelie, Agnes.
We don't have strict cutoffs for organ dysfunction scores, but it makes it more difficult, especially when it's acute. So we are more reluctant to put these patients on ECMO when you have acute multi-organ dysfunction, but not strict cutoffs of scores.
Okay. No, I guess I think the important message here is that you would do a sort of a multidisciplinary meeting, a discussion on, what's possible, what is recoverable, and then take a decision. Okay, thank you. Lee, shall I go to the next question, which is sort of relatively goes on, or should we move on and then come back?
We can move on and maybe come back to it.
Okay, sure.
just for the sake of time. So just moving on in our clinical case, the child was cannulated to VV ECMO. Some ECMO settings are, a flow of about 3,500 milliliters per minute and a sweep of 2,800 milliliters per minute and a sweep FiO2 around 100%. Ventilator settings were titrated down to some rest level settings. And the patient was weaning on vasoactives but remained oliguric despite a diuretic infusion. And just most recent lab values include a little bit of a low white blood cell count, a hemoglobin of 7.6, and a hematocrit of 22.8, and a platelet count of 75. And so I think big questions are, how are you managing these patients once they are actually on ECMO? And so for the immunocompromised patient, does there need to be any special things taken into consideration while they're on ECMO, any additional monitoring or interventions that would be required compared to your non-immunocompromised patient population? Dr. Potera, we'll start with you.
I think the thing that most of us worry about in these patients is the bleeding risk. Particularly if they are not engrafted and are more or less like resistant to platelet infusions, right? So at times we've done things like continuous platelet drips for these patients due to that risk. The other thing we worry about is because they're immunocompromised, are they at higher risk of getting more infections, central line infections, or other secondary infections that they might be exposed to in the hospital. So we maybe monitor them a little bit more closely as far as inflammatory markers and blood cultures on ECMO and things to that nature. But other than that, I wouldn't say that we treat them much differently than other patients who are on ECMO.
Do you have different transfusion parameters for these patients compared to your other patient populations on ECMO?
I would say we try to aim for a little bit higher platelet goal than otherwise, but as you know, there are studies going on right now to look at what is the right hemoglobin goal. I don't think that we know that yet, and hopefully coming soon will be a study to look at what is the right platelet goal. So right now we're just doing the best that we can based on retrospective studies, awaiting the results of these prospective studies.
And then for chemotherapy, do you adjust your chemotherapy based on the added volume of distribution that comes with the ECMO circuit? Dr. Reschke, I'll let you answer this one.
Yes. Yeah. So to answer the other question that came up in the chat, I would absolutely keep a new diagnosis on and just initiate chemotherapy. The dosing does get tricky on ECMO just with the increased volume of distribution and certain chemotherapeutic agents sticking to the ECMO circuit. And so that always becomes a conversation with both the oncology pharmacist as well as the ECMO pharmacist to figure out the specific dosing. So it gets complicated. And then obviously if a patient's on CRT as well, then that just adds another degree of complexity.
Yeah, certainly these patients can definitely be complex. For just the whole group, is there a particular anticoagulant that you think is best to use? And are there situations where you would recommend running without anticoagulation if tolerated? Dr. Zinter?
Well, we switched to bivalirudin recently and have good success with that. But I think I've certainly had patients bleed acutely when going on, even with just heparin boluses. So I'm very reticent to use anticoagulation up front unless it's really, really, really needed, or at least waiting a little bit. Or if you do go on, in the past we've given smaller doses of heparin bolus to go on. So I've seen patients bleed to death within an hour of going on from anticoagulation. So I'm more in that camp.
And Dr. Di Nardo, how about you guys? How do you manage your anticoagulation?
Well, I would say empirically for the platelet there is not really a threshold level that provide us safety, but at least we try to be over 20,000. For the rest of the anticoagulation, it depends. We are quite happy with vivalidine. We have also had some runs without anticoagulation. In general, when we have adolescent or patient that can tolerate more than 2-3 liters of blood flow, we saw that we didn't have, in line with our data, big problems in maintaining the platelet level or having problem in terms of oxygenator failure due to clots. I would not say that we do things different from the other patient. Just we are aware of maintaining the maximum level of platelet that we can, because as the colleagues said before, this platelet refractoriness prevent us to achieve what we want. And so we manage for what we have.
Great. I think we are getting close to the end of our time. I do have one final question I'm going to ask, and then we can maybe ask a couple of questions from the chat. Let's say this patient did not get better from a lung perspective. Is this child a candidate for a lung transplant, or is that something that could be considered in the future after a stem cell transplant if they were unable to separate? And then the reverse of that question is, would you put a time limit if you were not getting better and you did not feel that there was any future treatment? Would you put a time limit on ECMO? And so, Dr. Wösten-van Asperen, I'll start with you.
Oh, you start with the wrong one because I don't. No, I have no experience with this. We are our threshold for offering these patients a lung transplant is very, very high. So I should start with another one.
Okay. Well, Dr. Reschke, how about you? Any experience? I think Cincinnati is also a lung transplant center as well too, correct?
Yes, yeah. And so this actually gets at one of the eligibility questions in terms of ECMO candidacy, specifically looking at the reversibility of the underlying etiology. And so I think in this particular case, I don't think we know that this is a reversible cause. And so obviously the vignette couldn't get too detailed, but I would definitely advocate for a BAL and CT scan if you have a period of stability. Because we're right at that 3-month mark where we're kind of shifting from acute to chronic complications. And so you can see a lot of like the chronic bronchiolitis obliterans type complications that I think make it harder to justify ECMO candidacy. And that's the most likely reason that a patient would need to progress towards getting needing lung transplant. And I have never seen or heard of any success of like using ECMO to bridge to transplant for bronchiolitis obliterans, although I haven't looked at the literature for that specifically. But I personally would probably say a limited if you don't have a known etiology for the lung failure, I would do a 2-week time limited trial. And then in terms of the threshold for proceeding to lung transplant, institutionally, we use 2 years post BMT. And so we actually had a patient last year that another institution was willing to take them between 1 to 2 years. And so we did transfer that patient. They did successfully get transplanted at another institution. And so I'd say probably between 1 to 2 years is when the conversation typically starts.
Well, that's good to know. It looks like we have some questions in the chat, so want to get to some of those. So, Aparna, do you want to?
Yeah, this is an eligibility question, and I think it's quite an interesting one. How does the presence of GVHD change the eligibility for ECMO in these patients? Maybe I can start with Agnes. You're right at the top for me in this. Agnes, what do you think?
Yeah, I think our outcomes for VOD have improved. And so I wouldn't use having the presence of VOD as an exclusion criteria.
Okay. Matteo, Roelie, European view, please.
I didn't get for VOD or for GVHD?
It was GVHD, graft versus host disease.
Okay. For GVHD, in general, one of the things that we evaluate at the candidacy moment is if it is controlled or not with the best of the therapy. In generally, regardless ECMO, when the graft versus host disease is controlled, there is no contraindication to, I would say, intensive care unit admission, and so we will go on also on ECMO. When it doesn't work, so there is a refractoriness to treatment, this becomes a problem because the risk of failing during ECMO is higher, and the recovery, for example, of the lung is lower. So these are important points to assess if there is a refractoriness or not.
Yeah, I think good point there. Roelie, anything you want to add to this?
No, we have the same approach. It depends on how active the disease is. So it's a chronic, low activity, no contraindication. However, if you have a very active refractory graft versus host, eligibility will be much lower.
Yeah, sure. Matt, any thoughts?
I agree. Yeah, I strongly agree.
Okay, and finally, Renee, do you want to add anything to this?
I disagree with the other panelists, yes.
Yeah, okay. Sure, that's incredible. There is a question here about this is again, and a patient who was put on ECMO, and Justin has put this question to all of us here. In patients who were put on ECMO for ARDS, but later, while on ECMO, was found to be diagnosed with acute leukemia, high number of blood cells and blood film. Would you continue ECMO? And if so, how would you titrate chemotherapy while on ECMO? Who would like to go for that? Renee?
So I would continue ECMO, but I'm not an oncologist, so I would ask people like Dr. Reschke what she would do with the chemotherapy for that patient.
Okay, right. Go for it, Dr. Reschke.
Yeah, and I'd alluded to this specific question in one of my earlier comments. I would definitely continue ECMO on this patient and just have a conversation with both the oncology pharmacist and the ICU pharmacist to determine dosage.
Okay, Roelie, anything to add here from oncology?
No, fully agree.
Okay. Good. That's good. I think there's again, I think Matt, I saw you put a message here about the ECMO ventilation settings. Do you want to elaborate on that for everybody in the group?
Oh, I just, the part of the goal, not the entire goal, but part of the goal is to benefit from lung rest. But I think I typically just want to make sure that the circuit is working the way we think it is before you completely collapse the lungs, because it likely in this patient, delta 10 over 10 is going to lead to complete whiteout, and you're not going to be able to reventilate the lungs easily.
She likes to show up as well, which is and then she's not supposed to do it.
Sorry about that. Judith, can you mute, please?
Oh my God. Yeah.
Sorry.
I'm just focusing good. She's done a lot of.
All right. I think somebody accidentally unmuted.
Okay. Any other different approach for this issue of rest settings and managing the lung on ECMO in these children?
I think it depends on why the patient went on ECMO. If they have ARDS and are on very high vent settings and you're still not able to ventilate or oxygenate, then I do put those patients on rest settings. And, like Dr. Zinter said, you do want to make sure your ECMO circuit is working before you do that, because once you fully collapse the lungs, it's really hard to re-recruit. For patients who go on for sepsis, I don't always, go down to our traditional rest settings, depending on the severity of their lung disease. So it just, it depends on a few factors.
No, that's really good. I mean, I would say that these children probably are one of the most complex to manage on ECMO, and I think it's not going to be just one team, but multiple teams involved. And I would strongly believe that a multidisciplinary shared decision-making approach would be the right one for these children. And as we know that many of these children may not make it, and so supporting the families, supporting them with end-of-life treatment also, I think, is a very important part of the whole gamut of management strategies. Any final thoughts on this from any of the panelists? So I think we're coming to the end of the webinar now.
I guess any last minute thoughts about what you guys think needs to be studied in these patients going forward?
Okay.
I can take this one. I think we kind of alluded to some of the specific questions. I think one big one is the timing of initiation of ECMO in the context of someone's lung failure. If there's like a specific OI cutoff for a certain duration, I think our institution just uses arbitrary numbers. But I think if we can actually get data to support that, that'd be incredible. And then in response to Paige's question about organ dysfunction, I don't think we really know what degree of organ dysfunction affects ECMO outcomes. And so if there's, I think that also needs to be studied more.
Yeah, I would add not only research as to when to go on, but when to come off, right? Like we still don't know. There are reports of long-term ECMO patients. Are we just being impatient and trying to take these patients off too soon? Or don't think we know how that would change outcomes.
Yeah, all very important. Well, thank you to our panelists today. This was a great conversation. We have a QR code that I've had up for a little bit for feedback from the webinar. We'd love to hear from people about what we could do for future webinars, how they think that something could go better, other topics. And so please fill out the feedback form. And then we have just, again, here's the continuing education sort of registration, how you can do that. So thank you again to all our panelists. I really appreciate everybody joining and everybody's input. This was a great session.
Thank you, everyone. Real special thanks to our panelists. Really appreciate the efforts in making this webinar a success. Thank you.